Is Dr. Rani Raote, and her topic is Trauma and Talk Therapy, Brief Introduction to Trauma and the Limitations of Traditional Talk Therapy. Dr. Rani Raote has been working as a psychotherapist in Mumbai since 1992. She has had regular columns in the Times of India publications for 10 years and a radio program, Heart to Heart. She conducts workshops and group sessions for professionals and also for lay people. In 1999, she developed, supervised, and conducted a year-long internship program for counselors in training along the guidelines of American Psychological Association. Dr. Raote has worked with several NGOs like Dignity Foundation, FACSE, and Arpan. Welcome, Dr. Raote.
Okay, so I'm going to talk about trauma and therapy. Both of these are complex and vast topics. And obviously the time that we have today are not sufficient for that. But there is enough time for me to introduce to you, if you don't already know some of these concepts, some of you might know them, a couple of concepts which can be very helpful to you right away to understand the people you work with who have faced trauma. Whether you work with them in a teaching capacity, or you work with them in a legal capacity, and of course if you work with them in a therapeutic capacity. And the models, in fact, I hope that right in the middle of my session, you will begin to understand the model enough to predict and anticipate the rest of my talk. So my talk is going to be in 3 parts. In the first part, I'm going to talk to you about trauma. Very briefly, introduction to trauma. Then I'm going to talk to you about 2 very simple but profound concepts that guide every therapist's moment-to-moment decision-making within the session, in the large treatment planning, and like I said, it'll be useful in whichever capacity you work with trauma survivors or people who take care of trauma survivors. And in the last section of my session, I will talk to you about, based on the understanding that you've got in the first 2 things, how conventional talk therapy might fall short of really providing relief and healing to the trauma survivor. So I'm going to give you definitions of trauma that are used in our clinical work. Okay? The DSM-4 definition is an event outside the range of normal human experience that evokes horror, terror, etc., and from which there is no escape. The DSM-5 says exposure, which has just come out recently, says trauma is exposure to actual or threatened death, serious injury, or sexual violence via direct experience, witnessing it happening to a family member or friend, repeated exposure, for example, collecting human remains. So trauma can be divided into 2 large categories. One category of trauma are events that are outside the control of human functioning, like the earthquakes, the Nepal earthquake, the devastating floods, like we had in Uttarakhand, the tsunami, hurricanes, forest fires, landslides, avalanches, etc. The second category of trauma are those that are man-made or human-made trauma. And these are accidents, sexual violence, physical violence, stalking, kidnapping, acid attacks, which unfortunately we hear of a lot in India, dowry-related violence, etc. A couple of other ways of looking at trauma. Francine Shapiro, the developer of EMDR, which is eye movement desensitization and reprocessing therapy, talks about big T trauma, which are the obvious trauma events like natural disasters, car accidents, thefts, sexual violence like rape, child sexual abuse. Small t traumas are more the stuff of everyday life that goes unnoticed. So verbal aggression, discrimination based on gender or skin color, or negative comparisons. Research shows that it is the small t trauma that actually creates much more damage for the human psyche rather than the big T trauma. Another way of looking at trauma is a simple trauma. So simple trauma is exposure to one major trauma, while other areas of life are more or less intact. I say more or less because this is life. Everything cannot be perfect. So more or less everything else is intact. So for example, the support system is good. The person is intellectually successful, whether it's good in academics or in job, financial stability, emotional stability, and then is exposed to a major trauma like earthquake while visiting Nepal, or maybe a sudden car accident, or sudden loss of death of a spouse. So I was wondering when Dr. Engelbert talked this morning and said that not all child sexual abuse ends up in traumatized adults, that perhaps these cases might be where everything else might have been okay, and there was this one or couple of incidents, or even if that happened, maybe there was validation from the people around that, he's not a good guy who did it, and so that can help the recovery to be much faster. Contrast that to a complex trauma. Complex trauma is repeated exposure to traumatic events of varying intensity in the course of life, often starting from an early age at the hands of a close family member or other caregiver. So, what we typically see in India, okay? A young girl growing up in the slums witnesses daily violence, violent beatings of her mother at the hands of an alcoholic father. Father abandons the family for a second wife. Uncle molests her. She tries to run away, and so on and so forth. Now you can guess that this complex trauma is far more difficult and can take longer to treat than simple trauma. When we talk about trauma, it's important to remember that trauma is not the event. The traumatic event could be rape, okay, or a car accident. But trauma actually is the way that it is stored in our body, okay, the way it changes us after the event. Okay, so that's why, like yesterday when they were talking, I think Swati, when she was sharing the stories that came to them for Satyameva Jayate, some of them said that this happened years ago, but it is still fresh. That's because it's got nothing to do with the event. The event can happen yesterday, 5 years ago, 10 years ago, 50 years ago. The point is that trauma remains encoded in our bodies, in our brains, in our relationships, that we carry with us every moment. So trauma changes our brains, our minds, and our bodies. It changes us physically. Okay, research shows that it literally changes the brain and brain structures. It is carried in our body in terms of sensations or proclivities or urges. Trauma is stored in our bodies emotionally. There are some emotions that we can't feel anymore, except fear and danger and anxiety and worry. Trauma changes us cognitively or intellectually. It affects memory. We can remember traumatic events vividly, like flashbulb memories, or we may not remember them, but we feel the effects of them. It affects us in terms of the numerous negative, distorted beliefs that we have about ourselves. Trauma affects us in terms of our relationships, primarily our relationship with ourselves. There's self-loathing, hate, disgust, or a sense of not belonging. We just don't feel connected to our body and our sense of self. It affects our relationships with the world. with others. There is mistrust, suspiciousness, guardedness, or conversely, they can be indiscriminate trust and a sense of naivety. So, and it also affects our worldview. How do we begin to see the world around us? Typically, trauma changes our perception of the world. It no longer is a safe place where we feel in control or in charge of our lives. We feel vulnerable, victimized. It's no longer a safe place. Nothing good's going to happen, a sense of doom and gloom. The other sad thing about trauma is that if it's left untreated, it just carries on from generation to generation. So it's really, really important for us to identify trauma and begin to treat it. So if trauma affects us so deeply, that means it affects our brain, affects our nervous system. So I'm going to introduce you to two very simple concepts. Okay, one is Paul MacLean's triune brain. It simply means three brains in one. Okay, and of course the brain is not as simple as this. It's much, much more complex, but this is a good way, largely depicting how the brain functions, and an excellent way for us as lay people and as people who work with trauma survivors to have a sort of heuristic for us to work with. So it's one mind, three brains, okay? So the three brains, the three parts of the brain become the brainstem, which is at the bottom here. If I know how to do this, this is the brainstem, okay? This is located deep down at the back of our heads, right above the spinal cord. The brainstem controls our regular survival functions, things that we are not even aware of. Like right now, you've eaten a delicious meal, your body is digesting it, okay, it's regulating your blood sugar, it is regulating your oxygen levels, okay, your heart is beating. Much of this, you're not aware of this at all, okay? So the brainstem is involved with this automatic functioning of the body that is absolutely essential for survival. The brainstem continues to work even if you're asleep, okay? So it's continuously working to keep us alive and to keep us well. It's often also called the reptilian brain. No, I did something wrong here. Okay. And the brainstem, the language of the brainstem is body sensations and impulses. Okay? The next level above that is the limbic system, or it's called the mammalian brain, because that's what evolved next as the species evolved on this planet. This part of the brain is involved with emotions and relationships. And this part of the brain has a very important organ in it called the amygdala. And 2/3 of the cells of the amygdala are devoted to sensing and picking up danger. Because the job of the limbic system is to sense danger and to begin to alert us, in addition to forming relationships and having emotions of fear, joy, anger, and so on. The language of the limbic system is one of emotions and feelings. And then the last part is what we generally think of as the brain, which is that part involved with thinking, planning, recalling, decision making, listening as you're doing now, writing. All of this is part of what we call the frontal brain, or the neocortex, or the Homo sapiens brain. It's involved with, as it says, intellectual functioning, executive functioning, verbal language, conscious thought, self-awareness. and the language of that is thought and verbal expression. We need all these three parts of our brain to be working together. Okay? So I'm hoping right now you are feeling alert, okay, which would be part of your brainstem, and limbic system feeling safe and excited, maybe curious, interested, and your thinking brain is perhaps taking notes, criticizing it, saying, nah, this doesn't work, oh, I've heard this before. Okay, so it's all working together. This begins to work differently when we are under threat. This wasn't working like this at home, so that's why I'm a little puzzled. Okay, so when there is threat, okay, this could be environmental threat. Okay, so right now, God forbid, there is a huge, huge noise outside. We'd all probably startle. Okay, that would be a threat. Threat can also be interpersonal threat, disapproval, rejection, criticism, sarcasm, okay, abandonment. Okay, interpersonal threat is also part of this threat. So what happens when there is threat? That information comes in through the thalamus. Okay, it gathers that information, and the amygdala picks it up, which is the job of the amygdala to pick up any danger. And the minute it picks it up, it signals to another system in the brain, the hypothalamus, that this is danger. The minute it does that, remember the reptilian brain down here. What it does is that it picks up and then gets into our genetically programmed ways of protecting or fighting threat, which is fight. Either we have to fight off, flight, yes, freeze, submit and collapse, or we cry out for help. Okay? So this is what the brainstem does. But what is the neocortex doing at that time? It actually goes offline. Okay? Because survival is of utmost importance. And for that to happen, time is very crucial. So even nanoseconds that will be required to send the information up here for the amygdala to get it evaluated and say, is this really dangerous? Okay, that's wastage of time. So there's no time wasted. Instead, the amygdala signals the hypothalamus and the brainstem takes over with our typical ways of defending ourselves. Now, this is really important to remember. It works very efficiently when we are actually under threat. But what happens after the threat has passed? The amygdala has some very specialized functions. It is to also remember that these threatening events happened. It keeps a very close record of it so that in the future, if it sees anything even remotely similar to the original threatening environment, it doesn't bother to stop and check because, again, survival is important. So it's exactly at the airports. The detectors are meant to detect metal, whether it is metal in a gun or metal in your bone. It doesn't make a difference. It just starts beeping. So the amygdala is like that. It just senses even the vaguest signal to it that this could be threat is enough for it to start signaling to the brainstem that this is threat. This is important for us to remember because if the frontal cortex or the thinking brain is not involved and it is offline, what happens is that this thing continues to keep working whether or not we are under actual threat. That's what we mean by how trauma alters our brains. And I'm going to give you a simple model for you to learn this. Okay? Daniel Siegel is a very readable author. And in 2 of his books, he talks about the brain in the hand model. Okay, so I asked the house lights to be on for a reason. I want all of you to sort of put one of your hands up, okay, and then take your thumb, fold it inside, okay, put it at a comfortable distance, so, and then fold your fingers over. Okay, so what you have right now is a simple model of the brain in your hand. What you have is, this is your spinal cord, right? At the bottom here is the brainstem. That's the part of the brain that's involved with fight, flight, freeze, okay, and all of the automatic bodily functions. This thumb represents the limbic system and the amygdala. And the largest part, which is your fingers, which is also what happens in the brain, is the thinking brain, the neocortex. All right? Now, why am I teaching you this? Because this is something that I teach all my clients. And it very quickly helps them to understand, are they centered online, or are they disconnected? Because when we are under threat or we feel triggered, which means anything that reminds us of the original threat, this gets unhooked. And so what happens is, then we are no longer thinking, we are just reacting. Okay, which is why you remember that video on the girl Shikha and her friend on her mobile phone. Her grades started dropping. This is what happens to kids when they have trauma, because their thinking brain is no longer connected. Their brain is involved and preoccupied just with survival. Okay, so that's why grades drop. Children can't think. They can't be bothered with math and history and geography. It just doesn't make sense, because they've got to be, their brain, and this is not something that's volitionally done. This is what the brain automatically, instinctively does, simply to keep us alive and safe. Okay? So a simple example. It was raining 2 days ago in Bombay, right? So if it was raining like that and you happen to be going in a car, a comfortable AC car with the windows rolled up, and you're going dry as a bone in the car, and we have lots of potholes in Bombay, and so a passing car hits a pothole full of dirty water, and it comes as a flash, splash onto your window. What do? You just duck, right? And then you feel silly. It's like, but the window is closed. But you did that. Why? Because in that instant, your thinking brain was not consulted. The amygdala didn't say, hey, the water is coming, should we duck, should we not? There's no consultation. It's immediately duck because it could hit you. Okay? But this is how the brain of a trauma survivor is. Anything that seems remotely similar to the original event, it just goes offline, the thinking brain, the emotional brain, and all of those ways in which they coped in originally, okay, those come into play. So it brings up that fear, it brings up all those responses. So whether they played, whether they watched TV a lot, if that was their way of coping with the trauma, when they get triggered in adulthood, they're going to be finding similar ways of coping with that distress. Okay, so this is one idea. The second idea I want to present to you is the window of tolerance. Okay, another very, it's a simple, elegant concept, but so useful in moment-to-moment decision making. So our autonomic nervous system is constantly monitoring our arousal. Okay, it can go into high arousal, which I'm hoping and praying you are right now, listening to my presentation. But to be realistic, this is the 4th day of the thing. You've had a good lunch. Your body, you remember, your brainstem is sending all the blood to your stomach. The digestion is happening. You may very well be in this low arousal area. Okay? And this kind of a fluctuation between high and low is happening all the time when we are feeling safe. And actually, when we are feeling safe, we can even modulate that arousal. So, in case you're feeling here in the low arousal right now as you're listening to me, my hope is that you will say, no, no, I want to listen, I want to increase my arousal. You might sit up straight in your chair, okay, you might take notes, okay, you might pinch yourself a little bit, okay, you might listen more keenly. And what are you doing? You are raising your low arousal to a level where you can function the best right now. But when the autonomic nervous system senses threat, it takes our arousal system out of this window of tolerance into this hyper arousal zone. Because at that time, if there is threat, you need heightened levels of arousal to either fight, again, flee, and even freeze. Freeze actually falls in the hyperarousal state. So I was thinking again of what you said in the morning, that the group of teachers outside Chennai, when they couldn't say those sexual terms and they were sitting like this, you said, they were probably in the freeze mode because this was threatening. Okay? The amygdalas of their brains, for them it was threat. If you look at it just like, there is no threat, there is no life and death threat, but to that brain, which has got years of conditioning of being shamed or scolded or punished for saying sexually related words, the amygdala was signaling to the brainstem, no, 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 this is threat, and they just froze. They couldn't think, even though they were in an environment currently which was non-judgmental, accepting, and actually wanting to teach them to speak those words. Okay? If the hyperarousal level doesn't work, we can get anxious, we can get threatened, we are angry, want to fight, but there is no way of doing that. Then the autonomic nervous system moves us down here, again, to ensure survival. It's just like the new dog that enters the new pack and the rest of the dogs are there growling over him. What does that new dog do? Actually, literally puts his tail between his legs, bows down and says, okay, you guys are the boss. Submit and give in, because that's what's going to keep that dog alive in that pack, not fighting. Okay? So when we go into hyperarousal, this is what happens. We can dip down and conserve energy. When trauma happens, let me just put this whole thing up here. When trauma happens, our nervous system gets recalibrated in a way that keeps us in this chronic hyperarousal state anytime there are reminders of trauma. So we can get emotionally overwhelmed, panicked, impulsive, hypervigilant, defensive, feel unsafe, reactive, angry, there are racing thoughts. Or we can get down here in the chronic hyperarousal, numb, dead, passive, shame, given state. For any learning to happen, we have to be in the optimum zone where feelings and reactions are tolerable. We can think and feel simultaneously. Our reactions adapt to fit the situation. So that young boy that Ranjani was talking about, who couldn't sit still, okay, and we know from the comments that were made, has probably a trauma history, was up here in the hyper-aroused state, could not sit and think, could not learn. Okay? So now, from these two concepts, I'm going to quickly go over what happens in traditional therapy. So, the emotional catharsis. Sub-therapies will encourage the patients to vent out all the pent-up feelings and thoughts. They can have long sessions hoping that you can just get it out of your system, don't interrupt the person. So if you go back to the brain in the hand model, which part of the brain are they activating? It's the emotional thing, right? And for any learning to happen, and in the window of arousal, they're up in the hyperarousal, right? For learning to happen, for change to happen, for a recalibration to happen, the brain needs to be like this. So can you see how just giving vent to emotions is not going to help people to change? Similarly, the intellectual approaches. So you help people get insights and you say, it happened years ago. It's not happening now. You're safe. Okay? It's just an irrational belief. All men don't rape. See, look at your friend, look at the people in the organization. They are not raping you. So you're appealing to their thinking brain, right? But when their amygdala sees something that is similar to the original threat, what's going to happen? Is it going to remain like this, or it's going to disconnect? It's going to disconnect. So all the information that you've coached them is not available to them at the point where they really need to change. Then there are other ways in which we help our trauma clients. We do avoidance of distraction strategies, like, get a new job, just move to a new place, a new flat, get a new life. Okay? Don't think about the trauma. Just keep yourself busy. We tell them that just forget about it. Time will heal all wounds, and we know it doesn't. Because unless you remain alert to it, it doesn't heal automatically. You discourage them from talking about the trauma. Don't talk about it. You get upset, so don't talk about it. What are you doing? You're not allowing this trauma that is stored in these lower brains to get a chance to be resolved. Then you have some of us, some institutions I know, engage in scolding and punishing inmates and kids who cannot change their behaviors. Or they appeal and coax and bribe and blackmail. Promise me you'll not do this again. Okay? Promise on putting your hand on your child's head that you will never do this again. All of this can work till they get triggered. If they get triggered, the promises, they cannot think about the promises because the emotional and the body brain has taken over. So a good trauma treatment needs to have certain components. It's not about reliving and recalling the trauma, because that event is over. It is the way that it is stored in the body that needs to be worked on. It's the repair that we need to do, not just the recalling and reliving the event. We have to help the person be within the window of optimum arousal. Even as clients are talking to us, they get agitated, they get upset, or they go into a slump. We've got to help them be in that window of tolerance. Then the other thing is, we need to work with the patient. We need to educate them as to what is happening. All my clients know about the brain, and they know about the window of optimum arousal. That way they're able to monitor what's happening to them in the week. We need to engage the whole brain. And we need to do trauma treatment in phases. We need to start with stabilizing and educating them. Processing the trauma memories comes later. It's not important to talk about them. And then finally, we need to help them integrate back into their lives. Okay, this is a very brief, very concise, and the purpose of this is to pique your curiosity and encourage you to think more and read more about this.